Thank you very much. That's very interesting. Next up, we've got Ash Kumar, who's stepped in at very short notice for Matt Winkler. Ash has been central to some of the changes in London Deanery to the training programme. He's going to tell us about some of those now.
Thank you, Ben. I'm going to try and follow Prof's excellent talk. Nowhere near as impressive as Prof's talk has been. So I'm going to talk a little bit about group learning because there's been some changes to the training programme that we've had in North London. And as a trainee rep over the past 3 years, I've seen quite a lot of changes that have taken place to our training programme. And part of it involves group learning. We had a training programme that delivered some excellent results, particularly with the exams, with very high standards of training. But the world in which we live in requires a different type of trainee and a different type of consultant, and one that has to deal with very different pressures that perhaps aren't always addressed by a training programme that always just deals with the exams. And with the increasing role of hospital managers, of business cases, of financial constraints, of serious incidences that occur within our practice, there needed to be a recognition of these factors. And as Prof has touched on, the introduction of simulation training, the costs and the sustainability of such means that we needed to look at the way in which training was delivered within North London. The introduction of Health Education England gave an opportunity to try and change some of those aspects. And it wasn't really designed to try and negate what the excellent work that had been done before. It was more to try and add extra things to them, to try and mould it into a way that was more fit and purpose for the way in which the new training desires were going to be. So there were various things that were looked at. There was a balance that had to be achieved between training and service, the teaching programme, simulation programmes, as well as the professional skill set development, something that hadn't really been touched on previously through the training programme. And of course, the ultimate goal is not just about CCT, but just about being a consultant urologist equipped to cope with the rigours of daily consultant life. So, with respect to the teaching programme, there was the style of teaching programme needed to perhaps be a little bit more evolved. There was a lot of feedback from some of the trainees who felt that there would be an excellent opportunity to try and introduce some more adult learning methods, case-based discussions, MDT-style sessions, seminars, micro-teaching, and also sessions looking at exam techniques, something that I think trainees had fed back through various surveys that had been done, that perhaps it would be nice if we could try and have some more sort of Viva-style questioning, some more MCQ practice to try and help improve things from the training programme. The key thing from all of this was it was to try and improve the relationship that existed between the trainers and the trainees, and that was something that was felt as being quite key going through the actual evidence that had been gathered and put together. And of course, the most important thing with all of this has been the regular re-evaluations, which we've started doing, and those regular re-evaluations have allowed us to try and sort of fine-tune things in a very fluid situation. And you can see here that these are the actual ways in which we've so far achieved it. And I just wanted to touch on the one just at the bottom, which is a trainee charter that Ben and I are very heavily involved in. And that essentially lays out roles and responsibilities of the trainee as well as the trainers, with the ultimate goals that are laid out with the curriculum that has to be met, with a variety of different aspects as we go through our 5 years of training. The idea being that there shouldn't be any nasty surprises and we should get to the final end goal of achieving our CCT and being fully competent. Simulation training, I'm not going to touch too much on because Prof has touched on it already, and I'm really just going to say that there is the issue about limited funding and sustainability that has come through from our training programme management group meetings, and that's something that we are still working through. The one thing that Mr. Winkler has been very, very keen to focus on through the TPMG was the human factors. And the human factors training is something that he's been very keen to champion. Now, human factor training is essentially all about the interactions between humans and technical systems. As you can see here, there's a picture of an aeroplane cockpit, and it's something that's been looked at the airline industry with pilots in terms of trying to introduce the various tasks that are part of the actual process of achieving something, dissecting them and working out ways in which they go wrong, working out how to improve things. And even in my own trust, the nurses have been really very keen on this, something called SBAR, Situation Background Assessment and Recommendations. And they've essentially been trying to reduce the amount of poor communication episodes that have occurred in terms of daily ward practice, and it's worked wonders at trying to reduce the number of serious incidences and near misses that have come through. And as a consequence, one of the things that we've introduced has been the human factors training as a single day course once per year for the trainees, and at the moment it's been rolled out for the junior trainees, but obviously we've kind of said it'd be nice for some of the senior trainees to have access to that before they come to their CCT. Interprofessional collaborations. It's been well recognised that poor teamwork and miscommunication leads to errors and poor patient outcomes, and that's something that's been well established and forms part of such things such as the WHO checks. So from an interprofessional approach, Imperial College has been very keen to champion this, that the frontline staff across all specialties have to identify hindrances and improve communications amongst themselves. And we have small group workshops that have been done so far to try and develop those. And we've also introduced Myers-Briggs, which have come through. And Myers-Briggs assessments of different personality types was very warmly received by the trainees when it was performed last year, because it allowed them to identify what their own personality type is. And the external team that was invited in to teach us about Myers-Briggs allowed us to understand the different personality types and how they achieve things within different teams, and also about the different behaviours. But when things go wrong, one of the things that had been fed back from the trainees is that there wasn't much in the way of serious incident training. They didn't really know what to do, and much of it was kind of learnt on the job, which obviously is quite a good thing. You need to learn how to deal with various things, but it's not a good thing that you're actually involved in those situations when patients have actually come to harm at some point, or potentially at harm. So some of the things that have been focused on is what are the aspects of patient safety, how do we achieve in terms of teaching people about those things about patient safety and good medical record keeping and GMC's good medical practice. How are they investigated? That's been part of some of the training with simulated SI interviews as part of the new proposal that will be introduced soon. There's been a proposal, obviously, to try and introduce more case-based discussions where trainees are going to be carrying out root cause analysis of the WHO fishbone diagrams, and also there'll be the SMART recommendations with action plans formulated to try and help achieve a detailed list of what trainees might need to do in real-life situations, and then obviously hopefully apply this as consultants in the future. Paired learning. Now, Imperial, as the lead provider, this gentleman here, Dr. Bob Kleiber, was a paediatric trainee, and he recognised that the junior doctors and managers had absolutely no idea what they all did. So the managers thought the junior doctors were moaning and complaining about something that they didn't understand, and equally the junior doctors thought that the managers just sat in an office and drank tea and dictated to them what needed to happen. So there was evidence that's been looked at, and the NHS Institute for Innovation and Improvement in 2010 detailed that there was a clear link between the organisation's performance and the level of engagement between clinicians and managers. And that's something that has been the basis of the paired learning programme that has been developed, which is a peer learning initiative designed to try and address some of those and make people aware of the differences that occur within their working environment. NHS London, Leading for Health, the London Deanery, the NHS Institute for Innovation and Improvement have all acknowledged this and given their strong support towards this. And these are the aims of the paired learning programme. Essentially, to summarise, it's just trying to get a better working relationship amongst different departments. There's also something that's been introduced in terms of financial and business case training, something that a lot of trainees didn't, again, appreciate. How do you write a business case? Why do you need to write a business case? Why are we coding? And this is something that's been introduced as well, and it's been very warmly received. The other thing that Mr. Winkler's been very keen to promote is resilience training. There's obviously a long career ahead of most of the trainees, and there's going to be times when things are going to wax and wane. And part of the recognition of reliance training is to try and make sure that there are areas within kind of working life that are kind of dealt with. It's kind of work-life balance, but obviously trying to introduce some ways in which trainees can perhaps address some of those in the future and try and have strategies of how to cope when situations are slightly different for them. So overall, the changes for the training program have basically tried to build on what we had before, which was a very strong clinical and teaching program, try to adapt it, adjust it to make it a bit more relevant with new adult learning methods, and introduce a lot of professional skill sets into that to try and adjust it accordingly and trying to make it seem a bit more relevant and a bit more focused for the trainees. The trainees themselves so far have been very, very warm towards it. They've given plenty of positive feedback, and they're obviously very keen to continue with it. And the good thing about it from our point of view and from Ben's point of view is that we're actually able to have a first-hand role in this. There's been a change with our surgical training committee in the sense that we're actually now taking a bit more of a lead. We get feedback from the trainees, we're giving it direct to our trainers, and there's a bit more of a to and fro, a bit more of a relationship which is improved, and it's actually been much better for us overall, and hopefully it'll continue. And I'd just like to acknowledge Mr. Winkler, Mr. Giles Halliwell, Ben, and Imperial League Provider. I think we're leaving the questions till later.
Thank you very much.